Hello, I'm Margaret Brandwein-Weber. Thank you very much for joining me in this movie. The purpose of this movie is because there really is no substitute for experiential teaching. As I've written before, I don't think that you can adequately learn WPOI just from reading books or reading articles. And as with all pathology, I think it's best learned real time at the scope. So I hope to reproduce that experience with this movie. First, I'm going to discuss the rationale for migrating over from the whole risk model to just evaluating WPOI-5 as a sole variable. Then I'm going to discuss some brief background, concentrating on the 2013 validation study. And lastly, we'll go over the process of evaluating WPOI, and that will involve some embedded movies. So thank you for your attention.
This is from the 2013 phase 2 validation study, which included almost 300 patients with stage 1-2 oral cavity cancer, according to the 7th AJCC. I'm showing you the Cox regression analysis, which confirmed that the high-risk classification and WPOI-5 alone were both significantly predictive of local regional recurrence and disease-specific survival when adjusted for competing risks. This is the money slide that is the rationale for migrating from a 3-tiered risk system to evaluating a single variable, WPOI-5. The positive predictive value of WPOI-5 alone is almost 42%, meaning that for a patient with low stage WPOI-5 OCC, they have a 42% likelihood of developing local regional recurrence. And that's greater than the positive predictive value, which is almost 32%, for the high-risk classification, which is based on a combination of features and might not include WPOI-5. So the recommendation for evaluating a single feature as a binary answer, yes or no, as you see in the CAP protocol, will encourage its adaptation, thus getting the most impact for a single feature. Now, recognizing WPOI-5, just as all of pathology, can't be learned from just reading a description. Like all of pathology, you learn this through the experience of sitting at a microscope, receiving instruction, and reviewing slides. Only through the uniform application of definitions and criteria can we assure the reproducibility of its predictive performance. Here's a decision pathway for evaluating WPOI. You should have a copy of this next to you when you go over the study slides. WPOI is only evaluated at the tumor advancing edge or perimeter. Pathology sections need to be taken with this in mind. Ask yourself, is this a circumscribed cohesive tumor? If yes, it can be classified as non-aggressive pattern of invasion. Notice there's no need to distinguish between the WPOI types 1, 2, and 3. Are the satellites convincingly separate from the main tumor, but close by and not dispersed? We'll dive further into convincingly separate. If yes, then you evaluate satellite size. The cut point to 15 cells comes from historical reports. Just count the nuclei. If the satellites are small, meaning 15 or fewer nuclei per satellite, then the tumor is WPOI-4. Is this a dispersed tumor? This is a low power assessment, then supported by high power measurements. If there's 1 millimeter or more of normal intervening tissue between the satellites and main tumor, or between waves of satellites, then this tumor can be classified as WPOI-5. For dispersed tumor, the actual size of tumor satellites do not matter. So I just want to emphasize that point. Tumor circumscription is a feature that's very obvious at low power, as you see here. In your mind's eye, draw a line around the tumor perimeter. If you see normal intervening tissue within that perimeter, this tells you this is a non-circumscribed tumor. And that lack of that inclusion of normal tissue is obvious here at low power. And we see this here at high power. So obviously a non-circumscribed tumor. Here's another example of dispersion, which can be appreciated at low power. Here we see an ulcerated tumor, and I draw your attention here. So there looks to be a gap here with normal intervening tissue. At higher power, here's the end of the main tumor, and here's the beginning of the next group of satellites. So you would measure from here to here. So let's go through some teaching movies for WPOI-5 and 4. In case 1, I introduced the term waves of satellites, and you'll hear that more about that in case 2. This is a strandy pattern of tumor with large dispersed satellites. When we look close to the main tumor, we don't reach that 1 millimeter threshold for dispersion. So we need to look out into the periphery to find areas that satisfy that definition. Here we see an infiltrating tongue tumor. And the tumor is infiltrating in a strand-like pattern. We have convincingly separate tumor islands. Now, here's the same tumor. This is another section. And this section is showing us tumor dispersion. However, just by eyeballing it, this is not a millimeter yet. So we need to look out into other areas where we can find the diagnostic regions. Okay, so let's look here. Here at low power, we see there's quite a lot of interspersed normal tissue. So we can measure from the end of this wave until the beginning of this wave. We want to double check on high power to make sure we're not missing any intervening tumor satellites in between, and there aren't any. So let's measure from here until here. Okay, this is 1.9. So this can be classified as WPOI-5. Now, notice the definition includes a distance of dispersion from the main tumor to tumor satellites or waves of satellites. So these two satellites are closer together. This would be considered a wave. This is the next furthest or next closest wave. So while this is less than 1 millimeter, this is greater. And so this can be classified as WPOI-5. A frame of reference is important for measurement. Case 2 lacks the main tumor, but shows dispersed waves of satellites. So it's suitable to support the classification because it's a frame of reference for measurements. In contrast, if you have a slide that shows a single isolated satellite, this lacks a frame of reference. It supports the context of dispersion and should spur you on to hunt further, but that slide itself cannot be used for measurements. We see horizontal spread of squamous cell carcinoma right under the mucosa. At low power, we can see that there's carcinoma here and a wave here, a wave here. Here. So even though we don't have the main tumor in this slide, this is a fine slide to assess dispersion because we do have the context of waves. All right, so here's one wave. Here's part of the next wave. Measure from here.
to here. So that is 1.5. Now just for fun, let's see what this measurement is, how this goes. This is 0.8. So I thought that this would be less than a millimeter. And I'm also guessing this is going to be less than a millimeter. Fine. So these 3 islands here represent a wave. And we're measuring over to the next wave, which is more than a millimeter.
Case 3 shows an example of WPOI-5 by extratumoral perineural invasion. You'll also hear me mention bracketing of slides. This goes towards the idea of convincingly separate. More about that later. You'll hear me mention context of dispersion, as I mentioned before. This means the tumor satellites appear spread apart, and you just need to keep hunting for satellites which meet the threshold of 1 millimeter or greater.
So low power, tongue. You see bulky keratinizing squamous cell carcinoma. Big tongue here, carcinoma, probably connected here and other places. You see something that on low power looks like a separate island here. You see another group of separated islands here. I talk about the context of dispersion because it's very helpful in supporting that you have a WPOI-5. One of the limitations to WPOI-5 is when you have a bridge or a connection between what appears to be dispersed that is in the sort of next slide over. So when you're looking at something like this, be mindful to bracket your sections to support that there is no sort of connecting bridge between the main tumor and something like this. And here what we have is extratumoral perineural invasion. So remember that there are 3 phenotypes to WPOI-5. You can have dispersion throughout the soft tissue, and that's the most common phenotype. And those tumor satellites can be small, like we saw before. They can be large. There's no one particular phenotype that you would see with dispersed pattern. Could be stranding, could be keratinizing, and not stranding. The other 2 main patterns in WPOI-5 are extratumoral perineural invasion and extratumoral LBI. And so here we have an example of extratumoral perineural invasion that's responsible for the dispersion. Again, measured from here to here. Okay, this is over 2 millimeters.
Okay. Case 4 shows you an example of small and subtle islands which are dispersed. In the 8th AJCC, this would upstage a tumor as it impacts the depth of invasion.
Here's our next case. This is an infiltrating tongue carcinoma. We have these very large keratinizing tumor islands. It's very small, relatively small tumor islands. Now let's look at the next piece over here. Here's the main tumor. And we start to see, again, these infiltrating waves of squamous carcinoma. Again, here. There's more of this infiltrating groups of islands. They can be small and quite subtle. Let's go out here. Here we see a large group of nerves. And what do we have here? Another island of carcinoma. Notice the cobblestonic. So here's a good place to measure. And so really the next closest group of cancer islands is in this area here. Let's just check this out and make sure there's nothing in here. No, this is just lymphocytes. That's just a tissue fold. It's just a tissue fold. So really this is the end of this wave here. And we'll take our measurement from here until here. And we have 2.4 millimeters. So this is WPOI-5.
Now we're going to move on to WPOI-4 tumors, and you'll hear me mention tumor perimeter. This is relevant for separating WPOI-4 from non-aggressive pattern of invasion. In case 5, let the tumor perimeter help you decide if an island is convincingly separate or not. The determination of whether an island is convincingly separate or not is highly contextual to the case. You'll want to evaluate the tumor perimeter, the distance between the focus of interest and the perimeter, the shape of that island, and the direction of invasion. Rounded, smooth islands support convincingly separate islands. A feathery, irregular contour suggests interconnectedness. Let me show you some examples. Here you see sort of feathery perimeter here, the feathery contours. And so it's not hard to imagine that deeper levels would support that these are really interconnected. Here's another example. And again, it's not hard to imagine. You actually see it here. And so it's not hard to imagine that you would see it here or here, that deeper levels support that this is connected. So feathery contours or feathery shape does not support convincingly separate.
Here we have another tongue tumor, and we can see at low power the main tumor mass. It stands out very prominently from the inflamed background. And we also get a sense at low power of the tumor perimeter. So if you were to sort of draw a line, you know, watching where this hand goes, you can say, well, this is sort of the limiting border of the tumor. Well, recognizing the perimeter will help you recognize when something is beyond the perimeter. Like, for instance, an island like here, like here. So just back up to give us some context. Again, here's more of the tumor, another part of this bulky tumor. Here's a little island, really quite separate from these guys, convincingly separate, yet not dispersed to the point of being a 5. Let's just measure this, okay? Let's measure it from this area here. All right, that's like 0.3 millimeters. Let's go out looking for some other tumor satellites. Here's a tumor satellite convincingly separate, but not dispersed. Here's the original satellite that I was looking to show you. Quite obviously beyond the perimeter of the main tumor. So it's very separately, it's convincingly separate. This is way less than a millimeter, and this is small. Small is defined as 15 or fewer nuclei. So, you know, you want to look out and make sure there's nothing dispersed beyond this. And if that's the case, this is a nice example of pattern 4, based on convincingly separate small islands.
Lastly, case 6 is just another straightforward case of WPOI-4.
Here's another case of infiltrating squamous carcinoma. We see small, separate tumor islands. Okay, here we are at the advancing edge. Small islands, separate, non-dispersed, no measurement needed because it's obviously non-dispersed. Again, WPOI-4.
And that's the end.